As dentists, we use ionizing radiation for diagnostic imaging. However, it is well established that ionizing radiation poses a health hazard. The premise of diagnostic imaging is based on the principle that the benefits of imaging will outweigh the risks. In this video, I will discuss the risks from diagnostic dentomaxillofacial imaging with particular emphasis on radiation-induced cancer. I will also discuss the data that supports lack of hereditary effects from diagnostic imaging and lack of significant fetal effects from diagnostic dentomaxillofacial imaging. An understanding of these effects will allow you to comprehend the risks from dentomaxillofacial imaging. Exposure to X-ray photons causes DNA damage, which, if unrepaired, can result in cell death or DNA mutations. Of the various adverse outcomes, radiation-induced neoplasia is the only adverse effect of diagnostic dentomaxillofacial imaging. Now let's consider radiation-induced cancer. What is the evidence? What is the mechanism of radiation-induced cancer? And what are the clinical implications in diagnostic imaging? Cancer is a multi-step process in which a cell accumulates DNA mutations that provide it with a selective growth advantage. These mutations may occur sporadically or may be caused by exogenous insults, such as chemicals and ionizing radiation. There is strong evidence that ionizing radiation is carcinogenic. Studies of multiple human populations that were exposed to radiation, either intentionally or accidentally, have demonstrated this adverse event. These studies have shaped our current understanding of radiation carcinogenesis. We consider radiation carcinogenesis to be a stochastic effect, that there is no threshold below which the effect does not occur. Notably, there is a latent period between exposure and the occurrence of cancer. This latent period can be as short as a few years and is typically decades. Radiation-induced cancers cannot be distinguished either clinically or histologically from sporadically occurring cancers. This makes it difficult to identify radiation as the causative source. Perhaps most importantly, we know that the carcinogenic effects of radiation are tissue dependent. Certain tissues are more sensitive to radiation-induced cancer than others. These observations have important implications in diagnostic imaging. Considering that radiation carcinogenesis is a stochastic effect, we should consider that no dose of radiation is safe and that even smaller doses that we use in diagnostic imaging pose a small and often negligible risk. Our knowledge of the tissue sensitivity to radiation-induced carcinogenic effects guides our efforts to minimize radiation dose to those specific tissues during diagnostic imaging. And most importantly, the heightened sensitivity of children to radiation-induced cancer emphasizes the need to augment radiation protection and other methods to minimize dose when imaging children. Importantly, note that radiation-induced cancer has a latent period that often extends into decades. This emphasizes the needs to augment radiation protection in children who have a longer lifespan and thus might be more likely to manifest the cancer during their lifetime. Although the evidence for radiation-induced cancer is convincing, it is important to note that these effects have been observed at doses greater than 100 millisieverts. There's great uncertainty regarding the extrapolation of these risks to doses less than 100 millisieverts, which is the dose range of most diagnostic radiographic procedures. This uncertainty is highly debated in the radiation biology community. The current model of radiation protection is based on the linear no-threshold hypothesis, which predicts that there is a linear relationship between dose and the risk of inducing a new cancer even at very low doses. This hypothesis considers that there is no threshold and no safe dose. Proponents of this model emphasize the absence of a threshold and consider that even a single photon can cause complex damage to the DNA, the basis of cancer formation. It is important to remember that the linear no-threshold hypothesis is a model and is not a scientific fact. The assumptions of the linear no-threshold model have been challenged. These counter-arguments consider low doses of radiation induce adaptive responses, including upregulation of DNA repair, and propose the existence of a threshold or a less than linear dose-response relationship over the low dose range. Opponents of the LNT model argue that by applying an overly conservative approach, We compromise the full diagnostic benefits of imaging and increase the costs for implementation of radiation protection program. However, in the absence of scientific data that supports or negates any of the extrapolation models, radiation protection agencies have based their policies on the conservative approach of a linear no threshold hypothesis. Now let's review the tissues that are at risk for radiation-induced cancer from diagnostic dentomaxillofacial imaging. Exposure of the red bone marrow can increase the risk of leukemia. This risk is highest in children, sharply decreases when the age at exposure is more than 30 years. The thyroid gland is another sensitive organ that is exposed during both intraoral and extraoral imaging. Radiation-induced thyroid cancer is strongly dependent on age at exposure. The risk is highest in children, and there is little evidence for a dose response for individuals exposed during adulthood. Females are 2 to 3 times more susceptible than males to radiation-induced thyroid cancer. Patients treated with radiation for head and neck cancers have an increased incidence of salivary gland tumors. Likewise, this radiation-associated salivary gland tumor risk has also been demonstrated in survivors of the A-bomb. Finally, benign and malignant brain tumors are known to be radiation-associated, and considering that we often irradiate the brain during craniomaxillofacial imaging, we should be aware of this increased risk. So what is the anticipated cancer risk from diagnostic imaging? The International Council of Radiation Protection estimates that the cancer risk is approximately 5.5% per sievert. Doses from diagnostic dentomaxillofacial imaging are low, and this makes the cancer risk from these imaging procedures low and often negligible. So in summary, cancer risks from diagnostic dentomaxillofacial radiology exist, but are often very low and insignificant. Next, let's consider another stochastic effect of radiation, heritable effects of radiation. For the effect to be heritable, the mutation must occur in the germ cell of the parent. That is, the gonads must be irradiated during exposure. The mutation must be transmitted to the offspring, and the mutation must cause a phenotype to be recognized in the progeny. There is no demonstrable heritable effect of radiation in humans. However, such heritable effects have been observed in rodent studies, and that is the reason that radiation protection agencies choose to consider heritable effects as one of the effects of radiation. From a practical perspective, gonadal doses during dentomaxillofacial imaging are less than 10 microgray, making this practically non-existent for dentomaxillofacial imaging. A special consideration is imaging of pregnant patients where there is a potential to cause deleterious effects in the fetus. Data from human and animal studies have shown that the effects of radiation are dependent on dose and the gestational age during irradiation. It is anticipated that during pre-implantation, radiation might cause embryonic death. However, the threshold dose for this effect is 100 milligray, which is approximately 14,000 times more than the fetal dose from dentomaxillofacial imaging. Microcephaly and mental retardation are strongly associated with radiation exposure in utero. However, the threshold dose for these effects, approximately 0.3 gray, is 42,000 times higher than the fetal dose from dental imaging. Finally, there's also debate on whether radiation can induce cancer, a stochastic effect in the fetus similar to its effects in adults. However, the data on this is inconsistent, and this effect has not been observed at doses less than 10 milligray. This is much higher than the 10 microgray dose to the fetus from dentomaxillofacial imaging. These data emphasize the absence of any adverse effects on the fetus from dentomaxillofacial imaging, emphasizing the safety of this imaging when needed in a pregnant patient. Finally, let's consider radiation-induced cataracts. This is a deterministic effect and is often misconstrued by individuals to be significant during dental imaging. Studies have demonstrated that the threshold dose to cause radiation-induced cataracts is approximately 0.5 gray. Compare that to the lens dose from dental imaging. The threshold dose is more than 1,000-fold higher, emphasizing the absence of any effects on the lens from dentomaxillofacial imaging. So let's look at the practical use of this information. You use it to communicate risks of radiological imaging. You use it to make determinations for imaging pregnant patients. And you use it to direct radiation safety in children and in adults.